Hello, everyone, and welcome to FAIR's free monthly webinar series. My name is Carrie Molkowski, National Programs Manager at FAIR, and your moderator for today's presentation, Epi First, Epi Fast, Ask Questions Later. A little bit of housekeeping before we get started. This presentation will be recorded and posted on the FAIR website in about 7 to 10 days. Please note that for maintaining a quality recording, all attendees will be muted throughout the webinar. If time permits, we will respond to some moderated questions for our presenters at the end of the webinar, which you may submit throughout the broadcast. Because attendees will be muted, we ask that you please submit these via our questions feature in your GoToWebinar panel. For those of you on Twitter, we encourage you to join us in conversation during the broadcast. You can follow along with our webinar live tweets at our handle @foodallergy or hashtag FAIR webinar. Funding for this webinar was made possible in part through a 2016 grant from Mylan Specialty LP. We thank Dr. Russell, who serves as a guest speaker for this webinar and does not receive any compensation for his appearance. While Dr. Russell is not compensated for his work, he does receive our sincere appreciation for his time and efforts to help educate our community. Our key speaker today is Dr. Scott Russell. Dr. Russell grew up in Atlanta and graduated from Duke University, where he received a BS in biology and minor in chemistry. He received his MD from the Medical College of Georgia. Dr. Russell completed his pediatric residency and Pediatric Emergency Medicine fellowship training at University of Alabama, Birmingham. Upon completion of his fellowship training in 2008, Dr. Russell was appointed Assistant Professor, Department of Pediatrics, College of Medicine, Medical University of South Carolina. He was appointed the Medical Director of the Pediatric Emergency Department in 2011 and was recently named Senior Medical Director of the Medical University of South Carolina Children's Hospital and Division Chief of Pediatric Emergency Medicine. Dr. Russell is an appointed member of the Food Allergy and Anaphylaxis Emergency Care Task Force. He is also an appointed member of the Committee for Pediatric Emergency Medicine, American College of Emergency Medicine. He holds a fellow standing in both the American Academy of Pediatrics and American College of Emergency Physicians. Dr. Russell's research interests include anaphylaxis, trauma, asthma, minimizing diagnostic radiation exposure in children, and high-risk sexual behaviors in teenagers. He is co-investigator on 4 funded projects. He is author of 19 manuscripts, including 4 articles on anaphylaxis management, guidelines, and best practices. At this time, I am delighted to turn the presentation over to Dr. Russell.
Thanks for having me. It's really exciting to talk to all of you guys. This is my first webinar, so I'm knowing that most of you are parents of food allergy patients and the like. I'm much more afraid of you than you are of me, so feel free to chime in with questions and we'll try and address them at the end. So to begin, I'd like to start with some acknowledgments. This content that we're going to talk about today was modified from a presentation that we gave at the US Anaphylaxis Summit in 2016. It was prepared by me in conjunction with Dr. Dana Wallace, Stan Feynman, and Wes Sublett, who are all really, really smart allergists. And keep in mind that I am the medical equivalent of a caveman. Emergency physicians know a little bit about a lot of stuff, and I'm going to try and come from the perspective today of an acknowledgement of that and give you an idea of what we're thinking when you bring your children in to see us, and so that we can strategize together how we can do better and meet your needs better in the future, and how you can be the best advocate for your children. So the crux of anaphylaxis and the discussion around anaphylaxis seems to always revert back to what is the definition of anaphylaxis. So we're going to walk through a couple of different definitions of anaphylaxis and allergic reactions here in the next couple slides. So a food allergy, according to allergists, is an adverse reaction related to a food allergen that's caused by immunologic mechanisms. A systemic reaction is an allergic reaction that's not necessarily life-threatening, but it's limited to a single organ system or it has cutaneous or skin involvement and can extend beyond the immediate area of contact. And so again, this is an allergist definition. So it's not just at the point of contact, but has systemic manifestations. It becomes anaphylaxis when it becomes life-threatening and systemic, and it's related to this hypersensitivity. Whereas just an allergic reaction is just a local reaction. So it can get even more complicated than that. That last slide seems very complicated to me, but if you put up a slide about what an allergist thinks about when they see your child in their clinic, they think about it in all of these terms that really are confusing and potentially things that don't really matter to you as a parent. So they think about what the causes are, whether it's because of your immune system or immunologic, whether there is no known cause, which is the idiopathic thing that you see in the middle of the screen, or if it's non-immunologic, like there are people who are allergic to exercise and there are people who break out in hives when they're cold. And so all in all, what we're really speaking about today is this food allergies, which is immunologic, all the way on the left side of the screen, and that's a subset of human anaphylaxis. Again, as a parent, and really, quite frankly, as an ER physician, this slide doesn't really mean anything to me. I just want to treat the kids that are having a reaction and help them avoid having future reactions. So, in order to make it, quote unquote, more simple, the powers that be created what we consider clinical criteria for diagnosing anaphylaxis. So the National Committee of Allergy Immunology Diseases and FAIR, or this was FAN, but it's now FAIR. FAIR has been folded in. FAN has been folded into FAIR. Created a clinical diagnosis for diagnosing anaphylaxis, and it can be any one of the three big blue boxes. So it's an acute onset of an illness within minutes to hours, with involvement of your skin, mucosal tissue, which is your nose, your mouth, and at least one of the following. So you either have the skin manifestations and mucosal manifestations with respiratory compromise, meaning it's hard to breathe, reduced blood pressure, or symptoms of end organ dysfunction. So some of your other systems don't work. Well, that's really confusing. Another way that you can be diagnosed clinically for anaphylaxis is if you have two of the following list in the middle there. So you either have skin, itch, or swollen tongue. You have the respiratory compromised blood pressure or persistent gastrointestinal symptoms. So you can have anaphylaxis without having the skin manifestations. Okay, so the first box is you have skin plus something else. The second box is you may have two of the something else. And then the third box on the far right of your screen is you have an ingestion and you have basically cardiovascular compromise, or your blood pressure goes down and you get shocky and you get really sick. So the clinical criteria for diagnosing anaphylaxis is pretty complicated. If you're really in the heat of the moment and you're trying to say, okay, does this involve the skin? What else does it involve? Does it not involve the skin, but does it involve this? So again, I find the clinical criteria for diagnosing anaphylaxis confusing and maybe not particularly helpful to the parents that are taking care of their children and trying to decide what to do in an emergency situation. So I refer you to the caveman diagnosis, which, again, the first definition that I had with the big screen, whether it's immunologic or non-immunologic, is a great definition if you're an allergy immunologist. The clinical definition is great, and it's really helped us to do chart reviews and studies looking back on case series of patients that presented to different locations and how well they were treated and if we met standard of care. But at the end of the day, when it's your child or you're the ED practitioner and a child is presenting to you in the emergency department, it really comes down to a gut check. Does this look, sound, and smell like anaphylaxis, and what do the parents tell you it is? And that's really the way that I choose to diagnose anaphylaxis. And we'll go through a little bit more about what that means. So you guys probably know better than I do the signs and symptoms of anaphylaxis can really affect almost any organ system in your body. It can cause swelling in your face, runny nose, the swelling of your lips, tongues, and throat. It can affect your heart rate and create low blood pressure. You have skin findings, whether that be hives, itchiness, or just turning red. It can cause GI or pelvic pain. It can cause you to be confused, to have headaches, and definitely anxious. It can cause you to have shortness of breath, to cough or wheeze, and it can cause crampy abdominal pain, diarrhea, and vomiting. And it can cause loss of bladder control. So these things, when you're looking at a patient or you're looking at your child and you think or know that they've been exposed to an allergen, if you have some of this stuff, I would call it anaphylaxis. That's short and sweet, and it's not nearly as complicated as we try and make it out to be. So when we talk about the treatment of anaphylaxis, you'll see a bunch of signs like this and different ideas, but at the end of the day, if you go down any major guideline, whether it be the WAO guidelines, anaphylaxis practice parameter guidelines, the National Institute of Allergy and Infectious Disease guidelines, or ICON food allergy diet guidelines, I don't even know what all those groups stand for, but the important point is that the first line in every single guideline for treatment of anaphylaxis is that epinephrine is the primary drug of choice. And they say it a couple different ways, but the end result is the same. Epi, epi, epi is the only treatment of choice in an acute emergency situation for anaphylaxis. So all the other stuff is noise. If you don't hear anything else the rest of the day, epinephrine is the treatment of choice if you think your child has anaphylaxis, no matter who you talk to. So if epinephrine is the standard of care, I want to know, and I'm sure you want to know, why we're all scared to use it, right? I mean, it's if you go up to any ER physician or any allergist or any primary care physician or any parent, they will most likely be able to tell you that epinephrine is the choice medicine for this. But we don't seem to really do a good job of doing it. So let's go through a couple reasons why, and we'll look at it from a couple different perspectives. The first slide here is a list of reasons that patients report why they didn't use their auto-injector. Whether they didn't have one because it wasn't prescribed by their physician, they couldn't afford it, or they didn't fill it. When the reaction occurred, they didn't have it with them. The previous time that they had an allergic reaction, it got better on its own, so why would I give myself a shot if I didn't need to, or it was too expensive that I don't want to go get it refilled? My current reaction didn't really seem as bad as previous reactions, or it didn't really, it spontaneously resolved. I used another medicine like an H2 blocker or Benadryl, and it went away on its own. I'm taking a different medicine that will make epinephrine not work. I was told by my doctor that if I use epinephrine, I need to go to the emergency department, and I don't want to deal with a ambulance ride or the copay, or especially when they get better when I give the epinephrine, or I feel a lot better after I've given it. So why should I go pay somebody else to watch me? And I don't know what to do with epinephrine. I haven't ever used it before, or it progressed so fast that I didn't have time to use it. I would suspect that for all of the parents out there, some of these reasons have crossed their mind when they were deciding whether or not to use epinephrine for their kids or for yourselves. Of interest, if you take a second and think really hard about, well, okay, I made it to the emergency department, but I didn't get treated with epinephrine there. So what are some of the reasons that providers may not use epinephrine? And I think these are some of the most important things that I want you to think about, because when you're talking to an emergency room physician, this is what they may be thinking and not sharing with you. There's a historical bias about epinephrine. Most people from my generation and younger have only used epinephrine for two real situations. One is for a code. So somebody, we think of epinephrine as synonymous with needing to code a patient. So somebody is so sick that they're being intubated, they don't have a blood pressure, you give epinephrine. Well, that's true, but it's true that that's when we give IV epinephrine. When my mentors were training, there was no such thing as albuterol, for example, for asthma. And so the treatment of choice back in the day was to do subcutaneous shots of epinephrine. So the providers that came before me were much more comfortable with using epinephrine for a wider variety of symptoms or disease processes. So they used it more frequently. So people in my generation and behind me think of it as a medicine of last resort. We see a ton of kids in the emergency department, and I only see kids in the emergency department. So we see a ton of kids that come in for allergic reaction or anaphylaxis. And by the time I get to see them, or by the time my residents get to see them, a lot of times the resolution of symptoms has already occurred. So they're already back to normal, and that may be for a number of reasons that we'll talk about as we go through, but it creates a diagnosis bias for me. In other words, does this kid have anaphylaxis? Did this kid have anaphylaxis? Does this child have just an allergic reaction? And where does that leave me in the heat of the moment when I've got 20 other patients to go see and the child sitting in front of me looks great? Am I going to be more prone to call that resolved anaphylaxis or allergic reaction or what? So I think there's a diagnosis bias that keeps us away from using the term anaphylaxis. And we looked at the definition earlier, and it's not an easy definition. So for a caveman doc like myself, are we going to really sit down and spend the time to create the appropriate diagnosis? I bet you we probably find shortcuts and don't do a good job of that. The severe reactions that I see are really rare. And so that creates a system of pattern recognition. So I could see 700 different allergic reactions and only 50 of them are severe enough. And we'll go through some data later on from my original study in anaphylaxis that will show you how many charts that we had to review to find a good group of anaphylaxis patients to study. There's a fear of diagnosis error. So if I tell you that your child has an allergic reaction or anaphylaxis, that's going to create a whole new level stream of things that you need to do or are worried about. And there may be some physicians who don't want to create that strife for you or don't want to spend the amount of time talking to you about what it actually means. So we certainly don't want to be wrong, but if you're going to err on the side of being wrong or not talking about it, I certainly feel like we need to go ahead and over-diagnose it and let our allergist friends sort it out later. I'm sure you guys are all way too familiar with the cost of an epinephrine auto-injector. We actually use the EpiPens in my emergency department to treat patients that come in that we think are anaphylaxing. And I had a huge amount of work had to go into allowing our pharmacists allowing us to use it. But you come into my emergency department and you're a parent of a child with a food allergy or some other allergy, and we're going to hand you the EpiPen and actually make you administer it to your child or the patient administer it to themselves. But that's not a cheap way of dealing with it, and every year I have to fight with the administrations who are looking at the rising costs of the medications that we use in the hospital. That's the single most costly line item in our budget besides physician salaries. If you diagnose somebody with anaphylaxis, they're going to need to see an allergist, and that may not be possible in certain situations, and so it may lead to more diagnosis bias also. Again, we talked about the time that it takes to properly educate families, and you not to discriminate, but if a father brings their child to the ED and they may not be able to remember their child's birthday or how to spell their name, sometimes you're not really getting to the right person who's going to know how to take care of the allergy later, and you really need to spend the time to talk to other providers or anyone who takes care of the patient, and that is a costly endeavor when it comes to time in a busy emergency department. And again, remember, we're always dealing with who's in the waiting room, what ambulance is on their way, and what patients we're expecting from other services. So to do the right thing with a prolonged observation period and an investment in education actually takes a long time if you do it appropriately in the ED, and that may lead to challenge with other patients. None of that's right, but this is what your ED, your friendly ED provider is often thinking. So what is the standard of care from the National Institute of Allergy and Infectious Disease? Use of IM or intramuscular epinephrine is the treatment of choice. Educational instruction at discharge about avoidance of potential allergens and what to do if you have it. You need to give them a prescription for an epinephrine auto-injector, and many providers feel very strongly they shouldn't leave your ED unless they have one. So I've been known to send family members out to go get the auto-injector and come back so that I can go over how to use it before they're allowed to be discharged, and referral to a specialist. That's most typically an allergy or immunology doctor. So the big question is, this is the standard of care. Everybody, for the most part, routinely believes that this is the standard of care, but do we do a good job of actually practicing what we preach? So there is a Pediatric Health Information System, which is called PHIS for short. This is a lot of my slides will be very busy, but they're very simple in the message. This is a study that came out in 2016, about 10,442 patients that were coded at 35 different children's hospitals. Their medical record was coded to indicate that they had anaphylaxis. Okay, so over 10,000 patients treated in 35 children's hospitals and EDs for anaphylaxis that was labeled as anaphylaxis, which comes to about between 6 and 12 patients per 10,000 ED visits. So you read through this whole article, which is presented in one of the most rigorous emergency medicine journals, academic emergency medicine, from the best database that we have on pediatric care in the country, and they did not even report on the usage rate of epinephrine. Too many variations and too hard to study that. That doesn't sound to me like we were actually practicing what we preach. It should be the leading line that we report in any major study on anaphylaxis. So that's very disappointing to me. But I can understand this is a systemic study with way too many hospitals and way too many patients. So going back in history to when I first became interested in anaphylaxis was when I studied it as a fellow at University of Alabama at Birmingham. And we looked through over 800 charts of patients that were diagnosed with anaphylaxis or allergic reaction. Primarily, obviously, most of them were diagnosed with allergic reactions. But I read every single chart, and I used that clinical definition that we talked about earlier. Is it skin plus another organ system? Was it cardiovascular collapse, or was it more than one organ system involved with a likely exposure? And we came up with 124 patients that were treated over about a 5-year period, if I remember correctly, in my emergency department that I trained in. And we had about a 54% epinephrine dosing rate. But we were really, really good at giving Benadryl. We gave Benadryl to 92% of the patients that we're seeing. And when I calculated these numbers, I calculated them based on what they got before they got to the ED, or at least what was documented before they got there. And we were really, really good at using oral steroids. So we'll come back to this study, or at least this topic later. So going backwards, if the standard of care is giving epinephrine and giving them prescriptions and referring to a subspecialist, we didn't do really good there either. So I was super excited this last year when my Pediatric Emergency Medicine fellows decided to cover this study, which was released this year in the same journal that I released my study, which was basically a repeat of my study where they did the exact same thing. So they noted in this study that food allergy has doubled since basically when I was studying to when this paper came out. they looked at using a guideline regarding epi use. So they educated all their providers and taught them that we're not using sub-Q epi anymore, we're using intramuscular epi, and we need to treat with epi. And what they found, their pre and post guideline implementation rates was actually less after they educated all the providers. It went down from 57% to 41%, which is disappointing. The one thing that did improve was that after they implemented their guidelines, the proper administration use, so not sub-Q, which means right under the skin, but actually in the muscle, went up by about 40%. So that was good. But they were still really good at using antihistamines and steroids to treat anaphylaxis in their ED. So pretty disappointing. But does that mean our work is wasted? Probably not. But we still clearly do not practice what we preach. So we need to figure out what the things that are causing the fear of use of epinephrine for anaphylaxis. What's the rationale, and how can we look around it? So I'll take the next few minutes to explain to you why I think the fear of epinephrine is really bunk, and why anyone who has a standing interest in anaphylaxis or has a family member that has a severe enough allergy that we're worried about anaphylaxis, why we should be fighting for the continued use of epinephrine. And I found this quote. I honestly, to be quite frank, didn't know who Anthony Burgess was. He is an author and a musician who wrote the book Clockwork Orange, which I don't necessarily endorse the book or the movie, but I thought the comment that he made here, I concluded that there is as much sense in nonsense as there is nonsense in sense. Makes a little, sort of made me think about anaphylaxis and epinephrine. So there's a lot of bunk and a lot of nonsense in what we know and talk about epinephrine. So let's try and work our way through that a little bit. So first and foremost, the adverse side effects that people talk about, being tremulous or having anxiety or racing heart rate or feeling like the world is coming to an end, those actually may be good. The pharmacologic effects, or the things that epi does to you by any route, actually help you know that you've given enough epinephrine to potentially be helpful. And your body actually releases its own epinephrine or epinephrine derivative when you have an allergic reaction, which is why when you have severe allergic reaction, you feel tremulous, you have pallor, your anxiety, your heart rate goes up, and you feel dizzy. So some of the side effects that that people put with the effect of having an allergic reaction are actually your endogenous epinephrine that's been released. So what you're doing to give epinephrine is actually just bolstering the internal dose of adrenaline that your body releases. The serious side effects, which are arrhythmias of your heart beating funny, your blood pressure being too high, and other things, are really when you overdose or use the wrong administrative route, i.e. you give it IV or at a dose that's tenfold too higher. The side effects and the serious adverse effects are really never been reported with giving epinephrine in the muscle. The best study that we could find that talked about side effects were when the route, as you see in the middle that's highlighted, is intravenous. So they're actually putting the medicine straight into the IV. A quick anecdote about a patient we had in our emergency department before we switched to EpiPens. We had a patient that was having anaphylaxis, and people were getting really nervous. We didn't have the nurse didn't have the appropriate needle to give the medicine in the muscle, so she just took the dose and shoved it in the IV and gave it, and that's a tenfold overdose. And we had a few side effects from it, but nothing that was even terrible, and the kid did fine, got admitted, and we observed, and did fine. So if you're standing with an EpiPen and you are worried about the side effects of giving that epinephrine, if you give it correctly, you're not going to have any worries of any significant side effects. And when I say give it correctly, it means give it to the person who needs it, and don't stick it in your thumb, But if you put it in the muscle of the patient who's having an allergic reaction and follow the instructions, there are no fatal events from giving epinephrine, and the side effects are only beneficial for the treatment of the allergic reaction. So the first thing, if you're worried about adverse effects from giving epinephrine, that's bunk. Move on to the next concern. So this is a slide that, again, looks really busy. And the big thing that I will tell you to look at this is you cannot predict what your child or what any patient's future allergic reactions are going to be based on his or her past allergic reactions. So the blue bar is the first reaction, second bar is the yellow bar is the second, and third is the pink bar. And this indicates that a reaction can get significantly worse, and future reactions doesn't necessarily mean that it will. And each individual allergic reaction should be treated separately. So the take-home point to this is not that it's going to get worse every single time, but that you can't predict it, and that if you, just because your child or you got better without epinephrine at a previous allergic reaction, doesn't mean you don't have to give it this time. If you're thinking about it and you're nervous about it and you think your child is sick, give the epinephrine. Because just because I got better last time doesn't mean they will next time. The times that we see risk for increased risk for fatal anaphylactic reactions are when there's a delay of between the onset of symptoms and the administration of epinephrine or the treatment. Kids that have asthma, coexisting diagnosis of asthma, are much more at risk for fatal events when they have an allergic reaction. And depending on what the etiology is, drug reactions are often more dangerous. But you can't predict based on a history or any other really obvious diagnostic means who's going to have a fatal reaction. So give the epi. So I hope that most of you understand what a biphasic reaction is, and we go to a graph. There's a graphical picture of biphasic reaction that I think looks like we dropped out somehow. Let me go back. Sorry about that. Biphasic reaction is when you have a initial reaction that gets treated or stopped or spontaneously resolves, and then there's a period of time where patients act normally, and then you get a return of symptoms much later. And the return of symptoms can be less severe, the same, or more severe than the previous episode. So that's called a biphasic reaction or anaphylaxis. So there is some good evidence out there in a number of different studies that say that if you give epinephrine, you are less likely to have a biphasic reaction. So not only are you treating the patient faster, more consistently with the epinephrine in this situation, but it's also potentially preventing the return of symptoms later. So some of the data that supports that is if there was a delay, when they studied the kids that had biphasic reaction, the ones that had gotten epi much faster, so 48 minutes versus 190 minutes, the kids that got epinephrine earlier had a less likely chance to have a biphasic reaction. There was also the use of epinephrine at any point seemed to decrease the risk of having a biphasic reaction later. So early and fast and using it, and then again, the delay increased the risk of biphasic reaction. So using epinephrine reduces your risk. Using epinephrine fast reduces your risk for your symptoms coming back faster. So many of you have probably gone to the emergency department with your child, and either you got epinephrine en route or you got epinephrine after you got there, and we make you sit there. We make you sit there for 4 to 6 hours, or should make you sit there for 4 to 6 hours. And most of that that time you feel like we're doing nothing for you, but what we're doing is we're sort of observing and waiting to see if that biphasic reaction happens, because 75% or so of the biphasic reactions are picked up within that first 6-hour window. And so you're greatly reducing. If you sit in my emergency department and within 6 hours of having your epinephrine, you don't have a biphasic reaction, the likelihood, I can tell you when I send you home that the likelihood of you having a biphasic reaction is much smaller than if I just send you home right away. So again, a busy slide, a lot of science. The key points are this column in the gray box that says odds ratio. These are the only clinical predictors that were identified for how you predict a biphasic reaction. So clinical, not with the pre-existing conditions. So age 6 to 9, there's an odds ratio of 3.6, which means you're 3.6 times more likely to have a biphasic reaction. If you delay in your presentation from the initial onset greater than 90 minutes, that's a 2.6 or 260% increase in chance of having a biphasic reaction. Having a funky blood pressure at triage is an increased risk. Treatment of initial reaction with greater than 1 dose of epinephrine. So if you had to use more than 1 dose of epinephrine, that puts you at risk for having another biphasic reaction. And if you required albuterol or some other inhaled beta agonist like albuterol for an asthma-like symptoms. So there really is no association between having asthma and having a biphasic reaction, which is something that they see in adults. But about 15% of the patients that they studied had biphasic reactions, and 75%, as I mentioned earlier, happened within 6 hours of the original reaction. And a lot of the cases required additional doses of epinephrine later for the biphasic reaction. So again, not giving epi, delaying treatment, and delayed epinephrine and need for more than 1 dose of epinephrine puts you at increased risk for a biphasic reaction, or in other words, a return of the symptoms that could be worse. So the summary of all of that is that you may need 2 doses because of a biphasic reaction or a protracted course or just a really severe allergic reaction. A number of times you have to give more than 1 dose of epinephrine, and this will come up later when we talk about auto-injectors and the fact that they sell them in a pack of 2, and because of the increased cost of auto-injectors that people are facing, people are having a tendency to split their auto-injectors up, and that can be dangerous. And if the first dose doesn't work, you can give a second dose almost right away, so within the first 5 minutes. And Lord knows that if you're a parent, 5 minutes of watching your child have an allergic reaction seems like an eternity. And you can't predict, because last time they got better without epinephrine or last time they got better with 1 dose of epinephrine, you can't predict whether that'll be the same for the next event. So it's probably not a good idea to split your twin pack. So why epinephrine and not Benadryl? Well, there's some good science behind that. And again, this is a very scientific and busy slide, but I think you guys are clearly smart enough to see that 10 minutes to initial onset of action for IM epi. So if you give epi in the right location, you get both a higher concentration in your bloodstream at a faster rate than any other medicine, and it certainly, if you give it sub-Q, some of the original data showed that there was a delay and a lower concentration in the serum if you gave it sub-Q. So IM is definitely the better route, which is why the auto-injectors are such a good idea. And so before 10 minutes is up, you have a peak effect on your blood pressure, your heart rate, and all those other symptoms that show you that epinephrine is working. So how does that epinephrine onset of action compare to the onset of action for Benadryl and some of the other H2 antihistamines? So the big thing to see here is the top one is Benadryl. It takes 2 hours to really get to its peak effect. Hydroxyzine is the stronger one. It's Atarax. The other ones are some of the non-sedating like Claritin and Zyrtec. I think The third one there is Zyrtec, and the last one there is Claritin. So you'll see that Zyrtec typically works a little bit faster than Claritin, and I've seen this with my own sort of seasonal allergies. So Zyrtec is a little bit faster than Claritin, but none of that is acceptable if your child's having an acute allergic reaction. So here's another example of the same thing. This is even, this slide is oral antihistamines, and this slide is IM, or compared to PO, and I'm sorry that that doesn't project really well, but they tried giving the Benadryl in the muscle, and it worked faster, but really 50 minutes versus the less than 10 minutes for Epi. So it's really not a reasonable treatment of choice for an acute allergic reaction. So really, why do people give Benadryl at all? And one of the most memorable moments of my career in anaphylaxis, and talking about anaphylaxis, came from a ER physician out of Harvard, and he said the following quote that had stuck with me and I've used to educate everyone that works with me ever since. And it says, Benadryl is what you give to patients so that they don't itch while they die of anaphylaxis. And I think we have a lot of bias because kids don't always need epinephrine, and by the time we see them, they're always better. And we always seem to think that that is because they were given Benadryl. Well, they're more comfortable because they were given Benadryl, but it's probably not the thing that broke the allergic reaction or saved their life. It's probably either the endogenous epinephrine that they had, or the epinephrine that their family gave them, they gave themselves, or you gave them when they got to the ED. So if you want to really make an impression on people, repeat this quote: Benadryl is what you give patients so they don't itch while they die of anaphylaxis. So this is probably well within your knowledge range, and so it's probably redundant, but the emergency doses of epinephrine are 1 to 1,000. We give, when we draw it up, we give 0.3 milliliters for children and up to, I should say, 0.5 milliliters for adults. We give that intramuscularly, but it sure is a whole lot easier, and you get a lot less risk of error when you use auto-injectors. And I'm not advocating for one auto-injector versus another auto-injector. I'm not worried about that, but auto-injectors are a pre-filled solution that give you a pre-measured amount and give it quickly without the risk of error. And so 0.15 milligrams for a child between 15 and 30 kilograms, which is EpiPen Junior, and then the 0.3 milligrams for children over 30 kilos is the EpiPen Senior. With the current rate of increasing obesity in society, I wouldn't be surprised if there's a 0.5 milligram dose for kids in the near future. It is some ways probably safer to use an auto-injector in kids that are less than 50 kilos rather than drawing it up and giving it because of the errors that you can have when you're trying to draw it up in the heat of the moment. But really, those doses tend to work, so we really don't know what the optimal doses are. And is it okay to overdose children in epinephrine? Well, if you're giving an IM, it is okay to overdose kids, and sometimes it's actually probably preferred to use the EpiPen Senior rather than a Junior, especially if you go back and you think about those kids that we talked about earlier that are increased risk. So if they have asthma, if there is a severe allergy to some of the most common allergens like peanut, tree nut, milk, egg, fish, or seafood, if you're far away from an ED or you have a hard time getting a hold of EMS, if there is a family situation that you don't trust, it's rather than have too few EpiPens at too low of a dose, sometimes it's better just to give the one higher dose faster. And if they've had a previous life-threatening allergy, you'd rather just go ahead and give a higher dose. So for kids that are younger or smaller than 15 kilos, I'd rather just say, again, let's keep it simple because I'm a caveman. Just give them an EpiPen Junior. It's not going to hurt them. There's good evidence out there that it's not going to hurt them. And there is evidence out there that the sort of alternatives to auto-injectors don't really work well. I have tried to draw up epinephrine from an ampule, and I'm not good at it. and I do this every day for a living. The unsealed syringes that are prepared by allergists really don't have a prolonged shelf life. I complain about the 1-year shelf life for EpiPens, but if you have epinephrine put into an unsealed syringe, it's not going to last even that long. And so when you look at how hard this is the compelling data that I used in my group to really encourage people to let us use EpiPens. So if you take parents and ask them to draw up Epi with a syringe, a needle, and a vial, it takes them a long time. That's longer than 2 minutes average, which, again, we talked about if your child is having an allergic reaction, 2 minutes is a really long time. Physicians were a little bit better, and regular active duty nurses were a little bit better than us, and emergency physicians or emergency nurses were the best because they do it the most, but it's still a prolonged period. I mean, it literally takes 10 seconds to get an EpiPen, open it up, and give it in. So I would recommend not using the ampules in the real world and having to draw it up. There's some studies out there where they handed parents in Nashville a vial or a bottle of Tylenol, asked them to read the instructions and pull up the right dose for their kids, and they had a hard time doing it. And that's in a controlled setting when their kids aren't emergently sick. So I don't trust myself, so I certainly don't know that the real world supports using some of the vials of Epi, even though they're hundreds of dollars cheaper. All right, so we have a list of cases here, and I'll tell you what the commonality of these cases are later. I think we still have some time to go, so I'll try and go through these pretty quickly. It's not really a trick question. So there's a 2-year-old female with known egg and milk allergy who went to a county fair with her parents. She had a dinner roll that they got there, and within 30 minutes her parents noted that she's very irritable, she's flushed, and has several episodes of emesis, which means vomiting. She also appears to be scratching her face around her mouth. She has a history of seasonal allergies, asthma, and dry skin. Okay. Probably sounds familiar to many of you. Case 2 is an 8-year-old with a known peanut allergy. He's on a field trip. His teachers and administrators are aware of his peanut allergy. He eats a cupcake that were given to the students during the field trip, and within 10 minutes, he reports to his teachers that his stomach hurts and he needs to use the bathroom. On the way to the bathroom, the child has several episodes of vomiting and appears to have a hive rash on his face. Teacher, fearing an allergic reaction, calls EMS. When EMS arrives, the child is still looking flush. He has some hives, but he feels better. He also has a history of allergy, asthma, and dry skin. 13-year-old, or case 3 is a 14-year-old patient with asthma who has a known tree nut allergy. She's at school with her friends, setting up a stand to sell candy. Her teachers and administrators are aware of her allergy and her asthma. She eats a coffee-flavored chocolate that from a protein bar that was given to her by a friend. 30 minutes later, she reports that her stomach hurts, needs to use the bathroom. On the way to the bathroom, she throws up several times, has chest tightness and shortness of breath. She goes to a teacher, calls EMS, fearing that she's having an asthma attack. When the EMS arrives, the child still appears flushed to tachypneic. EMS supplies the supplemental oxygen, and she says that it helps her breathing. On arrival to the ED, her symptoms don't change. She has the same underlying comorbidities. So these 3 cases are all cases that are modified after fatal cases that were reported previously in the literature. So they're all a little bit different. They're all a little bit scary, and in some cases the kids felt a whole lot better by the time that they were seen in the emergency department, and sometimes they weren't. So again, it's hard to predict who's going to be the one that dies. From 2006 to 2009, the vast majority of hospitalizations and ED presentations for anaphylaxis didn't result in patient death. The case fatality rate is 0.3%. And so we talk a lot about it, but there is a bias in physicians that you're going to see that they see a ton of anaphylaxis. They see a lot of allergic reactions, but they rarely ever see severe ones, and they obviously, based on these numbers, rarely ever see ones that are fatal. So this is the barrier to the treatment that you have when you bring your child and you're advocating to your child for your child to get treatment, or you're trying to decide for it on your own. So what I would tell you as a caveman pediatric emergency doctor is that when it's your child, the statistics don't count. You need to be an advocate for your child, and that involves teaching them to carry their epinephrine wherever they are, teaching them how to dose it for themselves, giving it themselves if you need to, and making the ER physicians and nurses and teachers help you make sure your kids get epinephrine if they need it. These are my kids. That's Maddie and Tyler. I'm lucky enough that they don't have food allergies, and I thank God for that every day. But I'm talking to a lot of families out there that are fighting this every day, and the best advocate for your child is you. And if your physician is giving you guff as a primary care doctor, or your allergist is poo-pooing you and you feel like you need a better advocate, find a better advocate, because they're out there, and you can be the powerful influence in their life. So I wish you all nothing but the best, and I'm happy to take some questions if you have any, and we can see what we can address. Thank you.
Great. Thank you so much, Dr. Russell. That was pretty incredible and insightful to hear your perspective, even as a self-proclaimed caveman pediatric emergency doctor. So I think you covered so much good information, and as expected, we got several questions. So I think we have just, in the next 8 minutes, we'll try to get through as many as we can. So I'm going to get started right away. And you actually kind of talked about this on one of your slides when you were talking about the safest doses for epinephrine based on weight. But we had a couple questions come in, actually, kind of pertaining to this. So if a child is underweight, even for an EpiPen Junior, is there any concern with administering epinephrine? Can you just reiterate that point, please?
Yeah, I don't think so. I would give it. I think that the side effects from the relative overdose from an EpiPen Junior to somebody who's underweight is pales in comparison to the benefit of giving medicine.
You got that? Okay, great. Thank you. We got this from one of our moms listening, and you actually spoke a little bit on biphasic reactions and kind of what you would do in your ER. But she said that after her child was treated, they were discharged only about an hour later. As a mom, what can she do so that she's not kicked out after 1 hour, seeing as how research shows that you're supposed to be monitored for at least about 4 hours?
Yeah, it's a great question. And I don't know that you're going to win that battle necessarily face-to-face. It depends on who you're negotiating with. But I've had families report to me that they've gone out to the waiting room and sat in the waiting room and waited for that amount of time to make sure that those symptoms don't return. I would, again, I can't speak for every physician out there, and we should be listening to you. But if you say to them, look, I've done the research on this, and I'm concerned, and I want to observe him or her observe for a little bit longer, use data. It's hard to argue with data. 75% of biphasic reactions happen within the first 6 hours of the initial reaction. Now, if I'm seeing you 4 hours after the initial reaction and you finally get to the emergency department, I may watch you for an hour or so. Or if I have a really high-functioning family who can tell me exactly what they're going to do, have good transportation, and they seem like they want to go home, I'll send them home a little bit early if I know that I can expect them to come back. But on the contrary, if you're fighting for someone to pay attention to you and continue to observe, go stand somewhere close and check back in. Or if they don't listen to you, but they should be drowned by data. And if they're not, then you're in a difficult position.
Thank you. That's great advice. We have here a question. When blood pressure reduction happens during a reaction, what symptoms does that cause for the patient? For example, sleepiness, or does the patient pass out?
It's a little different in different people. It can present as altered mental status or confusion. It can present with dizziness. It can present with passing out. It's a little hard for the lay person without a blood pressure cuff to see it. It can cause a lot of just generalized swelling, but most of the time it's dizziness and confusion, and just really feeling bad and increased heart rate.
Okay, great. Thank you. In your opinion, is there such a thing as giving too many doses of epinephrine? Do you know, can it cause any organ damage?
The half-life is pretty short for epinephrine, so it really isn't an upper end of dosing range. Obviously, if you're giving one or more doses of epinephrine, you want to be seen at a facility so we can monitor your vital signs better. But it's kind of hard to say that there's an upper dosing limit when you're trying to reverse the signs and symptoms of severe anaphylaxis.
Great, thank you. So you definitely seem to get it, but how much new evidence-based practice is being shared with physicians in the ER that you know of course? This person said that it seems like not all ER physicians understand the rule of epi first, epi fast.
Yeah, we're trying. You know, if you take a step back and you look at the emergency physicians who are out there and the ones that you guys are interacting with most frequently, I would venture to say that very few of you are lucky enough to be at a major academic institution. So I have a bias, but pediatric emergency medicine facilities tend to be much more academic and much more up to date on the standard of care for things like anaphylaxis. But less than 25% of kids seen in emergency departments are taken care of by academic pediatric emergency physicians. The average emergency physician sees about 20% of his patients are pediatric patients, and then what percentage of those kids are really sick. So at your average community hospital, you're not seeing a pediatric emergency medicine physician, and you're potentially seeing somebody who's been out of practice or out of training for a long time and may or may not be up to date on the literature. So I think that's the steep learning curve that we're facing. We're trying to work with the American College of Emergency Physicians and train as many people as possible. I've done PSAs to ASAP and other places. We're trying to get the word out. So I think you're absolutely spot on that it's a problem, and I think FAIR and a number of the other groups are really working hard to get that message out to providers. And the other group is school nurses, right? I mean, we need to educate school nurses on this subject, and we're doing that also.
Definitely. Thank you so much. I agree. We're all working together to get some awareness around this. And so I know your time is so valuable, so if you don't mind, we've got maybe one more question that I could ask. Okay. So with the high price of epinephrine auto-injectors, you know, which we've all been hearing about lately, one mother wrote in that she had to split up her 2-pack. She asks, is it really all that important to carry 2 auto-injectors at the same time?
Well, the literature supports that it is. And the hard part is like I mentioned earlier, it's hard to predict when you're going to need that second dose, or if the next reaction is going to be worse than the first reaction. And I know that the times are tight and the prices are high, but I think making sure your auto-injector is within date and having more than one of them is the absolute best thing you can do for your children. I think it may seem over the top, but I think it's I think it's worth it. And at the end of the day, you're going to look back at that money and know that it's well spent to minimize the risk of not having enough with you. I think the only thing worse than not having it at all is not having enough. So I'd have to say yes.
Okay, great. Thank you. That's a great answer. All right. Well, I think that's about all the time that we have for today. So many questions poured in, and we really tried to answer them in the order that they were received. So I apologize if we did not get to yours. Just to mention, Thayer has a lot of resources for anaphylaxis management and on epinephrine on our website. And, of course, you can also check in and ask your allergist. I'd like to once again give a huge thank you to Dr. Russell for joining us and providing some really great insights about anaphylaxis and when to use epinephrine. I'd also like to ask you to join us next week for an additional anaphylaxis-related webinar, also made possible in part through a 2016 grant from Mylan Specialty. Dr. Spergel, Professor of Pediatrics at the Perelman School of Medicine at University of Pennsylvania and Chief of the Allergy Section at Children's Hospital of Philadelphia and Director of the Center for Pediatric Eosinophilic Disorders, will review the symptoms of allergic reactions to food, the indications for using epinephrine, and how epinephrine works in the body. That concludes today's webinar. Thanks again for joining us, and hope to see you again on Monday.